Good morning, everyone. I'm pleased to present this morning's Grand Round speaker, who is our current CNS endovascular surgery fellow, and is going to be spending the academic year with us. He is recently fresh from a two-year fellowship in spine in South Alabama, the University of South Alabama, where he had very high marks with his mentors there in terms of his professionalism, his patient care skills, and his burgeoning surgical skills. So he did his education in India at Mysore Medical College, where he graduated in 2003. He then went on to a general surgery program for 3 years, and then neurosurgery for an additional 3 years, as is the protocol in India, and graduated from his neurosurgical training at J.B. Pant Institute of Postgraduate Medical Education and Research. He subsequently, over the years, went through the credentialing process for American licensure with the step one and two and three exams and so forth. And uh, in the meantime, he continued to be a neurosurgeon in India from 2016 through 2023 as an assistant professor, and ultimately made his way to the U.S. And I can tell you that no one works harder than Sue. He goes by Suggala, by the way, or Sue, not by his first name, but by his surname. And has an academic track record with over 20 publications and peer-reviewed publications and numerous abstracts and oral presentations internationally. And we are really pleased to have him present today. I think that he has. It's been a few years since he'd done his endovascular training for his 250 prerequisite cases, and he's taken this last 6 months with incredible dedication and seriousness. He practically lives in the hospital. He takes attending call, and we're quite grateful for the work that he's been doing. So, Sue?
Yeah, thank you so much, Dr. Kim, for the kind words. I'm going to start off my presentation. Uh, Endovascular management of carotid cavernous fistulas. Now, the objective is to understand the pathophysiology, classification, clinical presentation, endovascular treatment principles, and to analyze the outcomes and complications. Now, as everyone knows, but just to reinforce that the carotid cavernous fistula is an abnormal communication between the ICA, ECA, or any one of their branches and the cavernous sinus. It's a rare pathology. 0.2% of patients with craniocerebral trauma present with it, around 4% with basilar skull fractures. Mostly unilateral, but bilateral can be seen in 1 to 2% of patients. The earliest understanding was from 19th century. Benjamin Travers, who he performed the first common carotid artery ligation. By 20th century, the fistulous connection between the artery and the sinus was established. It shifted the focus from an aneurysm to a AV shunt. Now, these are the earliest pictures showing from the Travers, Dr. Travers, pictures of patients before and after carotid ligation. And on the right side, you see an instrument which was designed to do carotid compression. Now, anatomy of the cavernous sinus is important to understand how we deal with this pathology. As you know, that the cavernous sinus extends anteriorly from the superior orbital fissure posteriorly to the petro-occipital fissure and the posterior petrous tip, and it is surrounded by on it is present on either sides of the sellar fossa. It has two layers. It's a dural envelope which consists of two layers, which is the meningeal dural layer and the periostic dural layer. The meningeal dural layer continues laterally to the middle cranial base, diaphragma sella, and to the tent and the sphenoid wing. The periostic layer contains the third, fourth, and first and second divisions of trigeminal nerve. The medial wall consists of only the meningeal dural layer. The internal cavity is trabeculated, contains the ICA, and lateral to the ICA is the sixth nerve. But sometimes anatomically it has been described that the position of ICA and the sixth nerve can vary. Sixth nerve may be in the wall, sixth nerve may be medial to the ICA, or ICA may be in the wall. That's particularly important to remember. Now, in 24% of the anatomical specimens, we might see something called as a laterocavernous sinus, which is a venous channel which is there on the outer wall of the cavernous sinus. It drains the superficial middle cerebral vein and the uncal vein and drains into the posterior part of the cavernous sinus, either in the superior petrosal sinus or in the pterygoid plexus, or in the posterior part of the cavernous sinus. The out and in of cavernous sinus has been described multiple times, but again, inflow consists of superior and inferior ophthalmic veins, the superficial and deep cerebral veins, and the sphenoparietal sinus, and the outflow is to the superior petrosal sinus, which drains into the transverse sinus, inferior petrosal sinus, the pterygoid plexus, and emissary veins from the foramen rotundum, ovale, and foramen vessalius. And both the cavernous sinuses are connected by means of a circular sinus. There is a plexus of veins, the basilar plexus of veins, on the clivus as well, which connects both the inferior petrosal and the superior petrosal sinuses. Now, the branches of cavernous sinus are a segment of the internal carotid artery are important because they are commonly involved in the pathology. The meningohypophyseal trunk, inferolateral trunk, and the capsular arteries are the main branches. The cavernous segment is again divided into five parts: the proximal ascending, proximal genu, the horizontal part, the distal genu, and distal ascending part. From the meningohypophyseal trunk, we get the artery of tentorium, dorsal meningeal artery, and the inferior hypophyseal artery. From the inferolateral, we get the tentorial branch and the anterior and posterior branch. The horizontal branch has been shown to be commonly involved in the traumatic carotid cavernous fistulas. Classification can involve based on hemodynamics, high flow, low flow. It can be spontaneous or traumatic, direct or indirect, or it can be based on the arterial supply. Barrow classified in 1985 type A, B, C, and D types of carotid cavernous fistula. A is the type which is direct, and it has a direct arterial supply because of a tear in the internal carotid artery. B, C, and D are indirect. B involves meningeal ICA branches, C involves the meningeal ECA branches, and D involves the ICA and ECA branches. Type A is usually high flow, and type B to D, which are indirect, they are usually low flow and also termed as cavernous sinus dural AV fistulas. The hemodynamic considerations are that the high flow shunt causes arterialization of the venous channels. There is retrograde flow causing proptosis, and there is cortical venous reflux, which increases the risk of hemorrhage. The etiology varies. Direct carotid cavernous fistulas can be traumatic or they can be spontaneous because of ICA aneurysm rupture or collagen vascular disorders. Uh, Indirect has possible two mechanisms. It can be due to breakdown of a small thin walled dural arteries or opening up of small anastomotic dural channels due to venous sinus thrombosis or elevated venous pressure. Athero, diabetes, hypertension, pregnancy, they're all risk factors for indirect fistulas. The classic dandy triad of pulsatile exophthalmos, orbital bruit, and chemosis can be a presentation. Additionally, diplopia, headache, vision loss, visual symptoms, raised ICP, venous hypertension, and tinnitus are observed. Um, the anterior drainage results in the red eye and eye symptoms. Posterior drainage may result only in white eye. You may not see the red eye at all. Cortical drainage can result in neurological symptoms of venous infarction or intraparenchymal hemorrhage. The reported percentage signs and symptoms of carotid cavernous fistulas have been variable. but it's been observed that the chemosis, proptosis, and nerve palsies are most consistently reported. Chemosis is nearly present in 100% of the patients. Subarachnoid or intracerebral hemorrhage is present in less than 5% of the patients. Cranial nerve deficits are usually in 5 to 33% of patients. Now, the features, the ophthalmological complications can involve ophthalmoplegia, vision loss, glaucoma due to raised orbital venous pressure, and venous stasis retinopathy. Now, important features which have to be identified in CCFs or carotid cavernous fistulas is that the corticovenous reflex can be seen up to 10 to 55 percentage of patients, and that can result in a hemorrhagic stroke. Often, subarachnoid hemorrhage is rare but often fatal, and there is always a risk of elevated intracranial pressure because of the resulting venous hypertension. Radiological diagnosis can be with the help of CT angiogram, where you see the early distension of the cavernous sinus and dilated superior ophthalmic vein. The MRI shows the flow voids. Time of flight MRA and contrast enhanced MRA are both useful investigations. But it is the diagnostic cerebral angiography, DSA, which is the gold standard because you can determine the type of fistula, you can tell the arterial supply, locate the fistula steer, evaluate the degree of AV shunting, analyze the venous drainage pathways, and identify the high risk features. Endovascular has been the mainstay of management, though conservative open surgery and radiosurgery have their own role. Conservative management particularly has been restricted to the manual carotid jugular venous compression, where they recommend use of contralateral hand 10 seconds each time, repeated 10 times, 4 to 6 times a day. The CCF may occlude in 35% of patients on a time range of 2 to 7 months. It is more so for indirect low flow carotid cavernous fistulas, whereas the direct high flow fistulas are not amenable for this treatment. Surgical treatment can involve the ligation, combined intradural, extradural approach, repair of the fistulous rent. But again, surgical treatment has a slightly higher morbidity and it's used only as a last resort. Radiosurgery has been shown in small studies, good occlusion, maybe around 95 to 93% over a period of 12 to 36 months are required for the radiosurgery to take effect, mainly for indirect low flow fistulas. Now, choice of treatment depends on the direct versus indirect CCFs, the size of the IC tier, the rate of AV shunting, and accessibility of the venous pathways. Generally, transarterial treatment is recommended for direct fistulas and transvenous for indirect fistulas. The armamentarium which is used are the coils, which can be 3D or helical, onyx or NBCA, which is the glue, and the covered stents and flow diverters. You can see here the balloons were used till 2024, but after 2024 they were taken out from the market because of increased risk of complications like spontaneous rupture, unintended location of embolization, and failure rates. Examples: Barrow type A post-traumatic high flow CCF treated with coiling, a 22-year-old male, fall from bike, ptosis, proptosis, and complete ophthalmoplegia, orbital bruit, DSA showing enlarged superior ophthalmic vein and dilated cavernous sinus, transarterial coiling going through the rent and coiling of the cavernous sinus, and patient serial clinical pictures showing complete resolution of the proptosis, but no resolution of ophthalmoplegia. Another example of a type A high flow direct treated with coiling here, 63-year-old female, a traumatic brain injury, traumatic subarachnoid hemorrhage. 2 weeks later, develops the eye symptoms, pulsatile pulsatile tinnitus, and whooshing sound. The fistula in the angiogram is at the level of the proximal genu of the cavernous ICA, You can see the dilated cavernous sinus and superior ophthalmic vein, and also you can see the contralateral cavernous sinus dilated with the fistula site being shown by the arrow. Um, Trans-arterial uh, access into the cavernous sinus, and initially superior ophthalmic vein coiled, and then the coils were progressed into the cavernous sinus, and from there the complete occlusion of the fistula was seen as the final result. Another example, type A, treatment with balloon assisted coiling in a 28-year-old male with eye symptoms, orbital bruit and tinnitus. Uh, Similar picture of enlarged cavernous sinus and superior ophthalmic vein. The balloon is located advanced, a soft complaint balloon at the site of the tear, and serial coiling is done, and that results in stasis and complete occlusion. And patient follow-up resulted in near complete resolution in 2 to 3 weeks. Now, balloon inflation can help to recognize the precise location of the fistula, stabilize the microcatheter when inflated at the level of the fistula's point, provide a buttress for coil deployment, and when embolics are used, it can prevent the embolic material from entering into the ICA. Again, balloon guide catheter, which is different from the balloon which is used. Balloon guide catheter, when used instead of the regular guide catheter and when inflated, it can help locate the fistula point, and it can slow down the contrast through the balloon guide catheter. And because of the decreased flow, it can help with the microcatheter positioning in the cavernous sinus. Again, one of the examples of a patient where onyx and coils were used to embolize, and the balloon inflation protected the rent and improved procedural effect. Um, Another example of a parent artery occlusion in a direct high flow cavernous CCF, 40-year-old male, head injury, skull base fractures. Um, uh, Patient had direct high flow fistula, and the ipsilateral hemisphere was supplied because of cross flow, and because of and one of the ways in which fistula site can be located is the Huber's maneuver, where ipsilateral vertebral artery shoot and ipsilateral carotid compression can result in a better visualization of the fistula, which was done in this case. But because of extreme tortuosity of the ICA, none of the maneuvers or none of the procedures were able to be done, and the parent artery occlusion had to be done, and that resulted in a good stable result with a good follow-up of the patient. Another type A fistula treated with covered stents, which also have a role. A 46-year-old male patient, a direct high flow fistula, cavernous sinus dilatation, balloon mounted covered PTFE covered stent introduced into the vertical part of the cavernous sinus of the carotid artery, and dilated, balloon dilatation, initial endo leak, more dilatation, and complete occlusion of the fistula, and a stable post-procedural follow-up. Covered stents are useful, but they have been told to have 98% success rate, but the real risk is uh, having dual antiplatelets, high incidence of vasospasm, difficulty in negotiating the balloon, the hardware to the cavernous sinus because of tortuosity. 30% risk of endo leak has also been reported. Now, flow diverters for type A fistulas have a very good role, and this is upcoming both upfront as well as assisted. In this 32-year-old female with a traumatic brain injury, multiple skull base fractures, started developing the pseudoaneurysm of the ICA. So she was diagnosed with pseudoaneurysm along with carotid cavernous fistula. You can see the pseudoaneurysm and dilated inferior petrosal sinus, dilated cavernous sinus, and transarterial route, though femoral vein access was also taken in this case as a backup. 3D RA shows the site of the pseudoaneurysm and serial coil placement in the pseudoaneurysm resulted in obliteration of the CCF. Endoluminal construction of the ICA, cavernous ICA, was done with the help of a flow diverter, and that resulted in good healing and a complete occlusion. So flow diverters have a good role. Long-term outcomes have yet to be decided because the data comes only from small retrospective studies, small case series, and the largest is of 53 patients. They have 90 to 100% cure rate, which has been proposed, and they can be used either solo or they can be assisted along with coils and along with coils. But the studies, no randomized trials have been done to compare the results of flow diverters with traditional embolization techniques. But they have been shown to have similar complication rates as with other procedures. Now, indirect cavernous fistulas, coming to their discussion, they have some distinct features. Because of the small arterial connections with the cavernous sinus, it's very difficult for the transarterial treatment to be executed. So the primary treatment for them is the transvenous embolizations, and because of the complexity of the arterial feeders. So the venous anatomy is really important to understand when you want to treat indirect fistula with with a venous access. As you see that the inferior internal jugular vein, in internal jugular vein, jugular bulb, it receives the inferior petrosal sinus. Superior temporal vein continues as the posterior auricular vein, retromandibular vein, and that communicates with the facial vein to form the common facial vein. The common facial vein again has communications with the supraorbital, angular, superior ophthalmic vein, which all drain into the cavernous sinus. So these routes can be exploited to access the cavernous sinus and to block the exit routes of the communication between the cavernous sinus and the arterial side for indirect carotid cavernous fistulas particularly. So examples, Barrow type D, carotid cavernous fistula, transvenous coiling through facial vein and superior ophthalmic vein route in a 69-year-old male patient who had a spontaneous onset of carotid cavernous fistula, indirect type, with eye symptoms and tinnitus and binocular diplopia. As you can see here, the feeders are from the cavernous ICA, and also there are internal maxillary artery feeders, which are artery to the foramen rotundum in the early arterial phase. In the late arterial phase, you can see the dilated superior ophthalmic vein. Now, contralateral cavernous sinus and superior ophthalmic vein is also dilated because of the increased flow. And we tried to access through the inferior petrosal sinus. The inferior petrosal sinus was occluded. There was only a stump, and it was a type C stump. The stumps of the inferior petrosal sinus can be divided into 6 types based on their communication with the internal jugular vein above or below the jugular foramen. This was a type C, and they're important for planning. And we were able to probe with the help of microwire. And after probing, we found that it was in the form of fenestrated channels and very difficult to reach to the cavernous sinus. So we use the triple coaxial catheter technique, which has been described previously in the literature, where we have a guide cath. Inside the guide cath, we support with the 033 distal access catheter, which is again supported internally with a microcatheter, which is again supported internally with a microwire. And this is a stable system which helps us to guide through the facial vein into the superior ophthalmic vein and into the cavernous sinus. And we take the microcatheter chute in the cavernous sinus, and fistula site identified and coils placed, and immediate result. was complete obliteration. Another example of type B fistula, inferior petrosal sinus, coiling root in an 18-year-old with a gunshot wound injury with multiple surgeries. In this patient, there was a MHT feeder from the cavernous ICA, and there was drainage through the IPS into the IJV. Attempted transarterial access was done. Microcatheter was advanced into the cavernous sinus because the arterial access failed, and then serial coils were placed, resulting in complete obliteration. One more inferior petrosal sinus coiling of a carotid cavernous fistula, indirect with feeders for left middle meningeal artery, uh, contralateral cavernous sinus, and you can see the corticovenous reflux in this case. Microcatheter advanced contralaterally into the cavernous sinus, and serial coils placed, and you can see the complete post-procedural obliteration ICA and the ECA runs. Inferior petrosal sinus is one of the most commonest way route to treatment of indirect fistulas. Like again, in this case, we see large number of IMAX feeders, IALT and MHT feeders, and dilated SOV. We coiled the superior ophthalmic vein, dipped down into the pterygoid plexus, coiled it, and then completed the coiling of the cavernous sinus, resulting in a complete obliteration. Now, sometimes, if everything fails, direct CT guided puncture of the cavernous sinus can also be done, like in this case of an indirect type D carotid cavernous fistula, which had MHT feeders and draining into the IPS. Bilateral IPS and facial vein access failed in this case. So under CT guided in the OR hybrid suite, a needle was introduced towards the cavernous sinus, and angiogram was done, and serial coils placed, and that resulted in complete occlusion. Superior ophthalmic vein puncture, especially in indirect, especially when it is arterialized because of high flow, can be done. Like in this case, where it is a type D indirect fistula of the large sac, which is arterialized. Open exposure can be done with the help of stay sutures, and the puncture can be done with a needle, and angiocath can be introduced, and through which the coils can be introduced. And you can see the post-procedural complete occlusion and the serial improvement in the patient. Transvenous strategy, the goal is to eliminate the shunt either by complete sinus packing or by selective shunt occlusion. Complete sinus packing is technically simpler, but because of entire sinus packing, there is a risk of cranial nerve palsy, which may be up to 77.8% when the volume exceeds more than 0.2 centimeter cube. So herein lies the concept of the shunted pouch, which has been described as a part of the cavernous sinus, often separate from the cavernous sinus, which is the epicenter of the carotid cavernous fistulas. And it can be located in the posterior medial part, posterior lateral part, the lateral part, commonly on the posterior end of the cavernous sinus. Uh, and if you do the selective shunt occlusion of the shunted pouch, which may be in the form of a pouch or multiple alleys, as seen in this figure, you can use lesser number of coils or lesser number of embolic material, and you can reduce the chances of cranial nerve palsy with minimal sinus packing and maintain the cavernous drainage pathways. When we can prefer the selective shunt occlusion, when we can identify the shunted pouch on MRA or angiography, and even after identification, it is possible in 85% of the patients. The steps are to identify and navigate into the shunted pouch. Uh, Always ensure that if selective shunt occlusion fails, you don't lose the access to the outflow pathways. Uh, Coming on to the complications in the endovascular treatment of carotid cavernous fistula, the cranial nerve palsies uh, mm, are the most frequent complications. Overall complication rate has been described 5 to 17%. Cranial lobe palsies have been described around uh, 2 to 26%. They're often transient. More than 80% of the cranial lobe palsies they recover. Um, the common nerves which are affected are the oculomotor nerve, sixth nerve, and the fourth nerve. Sixth nerve is the most commonly affected. Ischemic strokes and embolic infarcts have been described to be 2 to 3%, and they can cause the migration of the embolic material and can result in due to parent artery occlusion. Intracranial hemorrhage is less than 5%, but which is more common in the transvenous approach with and liquid embolics can be very fatal. Access site complications have been described like groin hematoma, 5 to 10%. Usually they are minor, rarely require intervention. And overall complication rates, coiling alone has 5 to 16%. Liquid embolics have slightly higher complication rates. Combined approach complication rates are similar to coiling, 5 to 16%. 3 to 8% is the permanent morbidity, and mortality is rare. Coiling has been proposed to be safer than liquid embolics, and liquid embolics have been described to have a high risk of cranial nerve palsy and overall complications. Transvenous approach has been shown to have higher efficacy and a lower risk than transarterial approaches. One of the retrospective review which was done in UW by the neurosurgery endovascular department, it studied 57 patients over a period of 1 year from 2000 to 2012 of CCF patients. Um, um, and the approach for these patients was either transarterial, transvenous, or a combination. And embolic materials were also used, like liquid agents like glue and onyx. And we had favorable radiological outcomes and clinical outcomes of 96%, which match with other studies, and only 6% procedural morbidity. And the transarterial route was done in 27 patients for direct carotid cavernous fistulas and 4 patients of indirect fistulas. Transvenous was done in 2 cases of direct fistulas and 16 indirect fistulas. Overall, there were 57 patients, 35 of them direct fistulas, and 22 patients had indirect fistulas. Combined transarterial and transvenous was done in 2 patients. In this particular patient, at that point of time, the first reported case of embolization of carotid cavernous fistula through the arterialized frontal vein approach was described, as you can see in this case, where an arterialized frontal vein was used to access the cavernous sinus because all the other routes had closed because of multiple treatments before. Uh, so that resulted in good occlusion. Uh, so coming to the outcomes as described, chemosis and proptosis resolves within hours to days, and cranial nerve palsies resolve over the course of several weeks. Vision recovery is dependent on the duration and severity of the pre-intervention deficit. Recurrence is uncommon, but of course, recurrence can be treated with repeat embolization, and repeat embolization is easier if we take into consideration the number of options, including venous, transvenous, and transarterial. So to conclude, carotid cavernous fistulas are challenging lesions to diagnose and manage. We need to have multidisciplinary approach. The operator or the surgeon should have multiple options in his hand, which includes transarterial, transvenous. Gold standard is DSA. And complete obliteration with ICA preservation is the target and is the treatment of choice, but may not be possible in every case. Um, and in select cases, conservative treatment, right, radiosurgery and conservative treatment can be offered. Thank you.
Nice job, Sue. I have a couple questions, but I'll open it up to the audience first. Any questions from anyone? Otherwise, I can start. You briefly mentioned covered stenting, and I think the history of covered stenting in the United States has been um, lackluster in terms of the initial effect is amazing, but it has a very high rate of rethrombosis and occlusion, and potentially complications if the carotid occlusion cannot be tolerated. So the practice has moved away from it. More recently, however, there's a new device in cardiology that has arisen, and the technological advantage is that it is a different way of manufacturing the covered part of the stent onto the scaffold of the stent itself, which used to be sort of like a sandwich where you have a metal stent and then two layers of PTFE on either side to act as the covering. But that is a lot of material and a lot of thickness to the stent that leads to thrombosis and in-stent stenosis and those kinds of problems. Whereas the PK papyrus stent is a more thinner design. It's a more easily deployable design. And so I think that everyone's revisiting this whole thing. But I think these kinds of technologies, and you talk about liquid embolics and all that, I would say that they do not necessarily improve the safety of the procedure, and they don't
Mhm.
necessarily improve the efficacy of the procedure when you use transvenous or transarterial coil embolization or some sort of traditional technique. So, what is the real value of those other techniques other than the technological advancement of a different technique? And is there a justification in your mind to using those techniques when sort of the old school way of doing things is equally safe or safer and equally effective?
Mm. Uh, So the use of newer techniques like flow diverters, for example, which I mentioned, um, most of the studies are small. Even the largest study has only 57 patients, 6 months or 1 year follow-up. But what I thought is that it might have more role in add-on treatment, like for example, as I showed in the case where post-coiling the endoluminal reconstruction, the flow diverter was used. Versus using it as an upfront for treatment for a flow diverter. But of course, these are my preliminary understandings. I still need to see more cases and understand the
Yeah,
pathophysiology.
so what I was getting at is the studies are preliminary, you're right, but they're not going to show any safer outcomes or better outcomes than traditional ways. But the reason why they're popular is for one of the most common reasons why any device in any surgical specialty is popular is that it speeds the procedure up in terms of the time it takes to treat things. And in my opinion, that's one of the leading reasons why flow diverting stents is so popular for aneurysm treatment, for example, isn't because it's such a great device in every instance, but it is just a faster device. It takes 20 minutes to do a flow diverter case once you get everything in position. And I think that these newer techniques in cavernous carotid fistula management is the same thing. It's just faster to drop a covered stent. It's faster to throw a few coils in and then just slap on a covered stent. I mean, a flow diverting stent. The issue I have with that is that it isn't safer. It's more risk and it's more serious risk, but it's rare. It's still very rare, but you can't get below 3% for flow diverting stents. You're talking about 3% risk of stroke, thrombosis, severe in-stent stenosis, ischemia, that kind of thing. And that's not trivial compared to the thrombobolic risks of transvenous or transarterial. coil embolization, which is extremely low. And on top of the fact that there are numerous papers more recently, there have been some where partially treated cavernous carotid fistulas have an incredibly high rate of subsequent thrombosis, something like 90 to 95%, even if you don't do a perfect job, just by
Mhm.
throwing some stuff in there and acting as a nidus for thrombus propagation. The only danger of partial treatment, of course, is that if you leave the superior ophthalmic vein uncovered, then you may convert it into a recurrence that flows out through the SOV because of the anterior location in the cavernous sinus of that vein. But in my mind, there's not a lot of benefit other than you reduce the radiation time and the speed of the case. But because of that convenience, I can assure you that that is the direction that the management of cavernous carotid fistulas is going to go. That and also the incredible pull marketing and push marketing of industry to push these expensive devices onto our surgeons and our thought leaders and so forth.
Thank
Yeah,
you.
I would echo that. I would say that to me, the biggest advancement in the treatment of cavernous carotid fistulas in the 10 years that I've been in practice is the penumbra swift pack coil because it's really long. Because you can get a 60 centimeter coil into the cavernous sinus. But I agree with Lewis. When I was in my fellowship, we would routinely for indirect fistulas, we would coil the venous pouch, but we would also have onyx. We would drop pipelines. We do all this stuff, and it was very. It made me very nervous, um, and it wasn't necessarily better. And I think the stepwise, simple, straightforward solution, if it's a direct fistula, coil off the pouch through transarterially. If it's an indirect fistula, coil off the pouch transvenously. And like all these other things, I think you can reach for them if that stuff doesn't work and you're starting to get nervous that you're not going to be able to fix it. But it's pretty rare that that stuff doesn't work. I think these cases are a study in venous anatomy, and getting to the fistula is often the most challenging part. And once you get there, then you're kind of off to the races. And the last thing I would say, the pearl that I've always thought is, particularly for direct fistulas, the risk is to the vision. And so you really, for a direct fistula, you need to know what the intraocular pressures are. If the intraocular pressures are high, personally, I think that's an emergency case. A patient can lose vision if their intraocular pressures are high. You got to do that very soon. And the key is you gotta at least coil off the SOV and the IOV, the superior and inferior ophthalmic veins. You have to close those off to the hypertensive flow of the fistula to protect the eye. And then the rest of the fistula, of course, you want to deal with to prevent all the other complications that you said. But you got to at least disconnect the eye. So those are the two things that I've sort of learned over the years. But these are incredibly complex cases. They're intellectually challenging, but the actual treatment should be as simple as possible. So I agree with Lewis on all of that.
Thank you, Dr. Levitt.